We will be discussing about some of the debates focusing on the critical patient. We are not exempt from debates which are very old, but they regularly come up again for those that start working in the ICU. So I want to thank the organizing committee for the invitation, Dr. Jose Manuel Gomez Garcia, and myself to take care of this session. I have to talk about admission criteria to the ICU, whether there are any updates. From the point of view of bioethics, it is very difficult to establish technical criteria to govern admission to an ICU. So my presentation is not addressed to establishing those criteria. Most of these criteria are determined by the other specialties that use our services and refer their patients to us. So the ICU is not the one that usually establishes admission criteria, though in the end, we are the ones that make the final decision whether to admit the patient or not. Well, when the theory of common death theories failed breathing, that's time zero. And this theory was published recently, back in 1974, when Finn published his study. So respiratory failure is always present, and this is one of the guiding factors for the treatment in the ICU. And in Spain in particular, in general, we follow these priority criteria, which classify patients into priority 1 and 2, patients in whom the intensivist is the one that determines their admission, to priority 3 and 4, where the admission criterion is more difficult to determine. We really have to be convinced of the reasons why the patient has to be admitted to the ICU. And in the specific case of two pathologies that I will be discussing in my presentation, in the case of obstructive pulmonary disease, that could be priorities 2 or 3, and in the case of cancer, lung cancer in particular, lung cancer many times was priority number 4. We systematically rejected their admission. And what is the current situation? Well, there has been a significant increase in the number of elderly and very elderly patients admitted to the ICU. That was not the rule. Age underestimated in many cases admission to the ICU, but in recent statistics, it has been documented that from 1998 to 2008, there was a 15% increase in the number of patients over 80 years old admitted to the European ICUs. So in Spain, it's even higher because the population pyramid in Spain shows that there is an increasing number of elderly population. And the second idea is the post-ICU syndrome. And the concern here is addressed to our ability to preserve a good quality of life, functionality, and autonomy of the patient. So we are trying to respond to that historical demand of the lack of follow-up in terms of statistics of poor recovery after leaving the ICU. Not just mortality, but there is a high percentage of those patients that can't go back home, but they are referred to care centers, long-term care centers, because their situation does not enable to go back home. They are not autonomous enough. In the case of COPD, with the exception of the last 2 decades and the inclusion of non-invasive mechanical ventilation, not much progress has been made. We get tables of criteria talking about severe COPD, multiple admissions, very reduced functional capacity. And beyond that, many intensivists are still reproducing this, which was already manifested in an article published in 2021. And I am going to discuss those conclusions. That article is based on a survey administered among ICU physicians. And at that time, 20% of the physicians would deny admission to patients for the mere fact of being 80 years and older. This has changed because of the trend I just mentioned. We now have an elderly population, an increasingly old population. We use the criteria of CO2 arterial pressure as another criteria to underestimate the patient. But this has changed as well because the cornerstone of COPD is the systemic and persistent elevation of CO2 levels that with non-invasive mechanical ventilation can be significantly improved. And 30% of the physicians surveyed also denied admission if the patient had been admitted twice during the last year. There has been an increase in the number of patients with severe COPD. However, with regards to this survey, something was really striking. An additional survey has been made recently, and the information told us that about 10% of the people surveyed would have admitted the patient even against their own will, understanding that their will was limited because of the hypercapnic encephalopathy. But there is a doubt of whether that criteria was not being liberally used to dismiss the decisions that the patient made autonomously beforehand. So these changes occur based on these initial results. And I am going to show you some changes that have taken place regarding COPD, which is much more permissive, older age with a higher number of admissions, and the increasing role of the ability of the patient to make a decision which prevails on top of the medical criteria. And another reminder, according to the guidelines, is that admission should not be restricted to the ICU to decompensated patients that require negative ventilation, and we should try to avoid that discrimination. This still happens when we analyze the individual admission criteria. And on the other hand, the guidelines cannot consider all underlying pathologies of patients with COPD. So I insist, beyond the typical criteria of COPD, we must always base ourselves on an individualized decision and the wish of the patient. The will or the wish of the patient is one of the big progresses we have been making because we didn't take them into account. And the second aspect, which is lung cancer, what we have to recall is that the incidence has significantly increased. In the case of Spain, it's the first cause of mortality according to the recent statistics. It's almost the first or the second one in importance in the case of women because of smoking mainly. The history of lung cancer has evolved from a generic concept to a more modern concept, which goes into the molecular subtype. Big progress is being constantly made, and the classical definition between small cells and non-small cell cancer is no longer valid. We are at a phase in which we must clearly know what does it mean when a lung cancer expresses, for instance, a mutation or a positive KRAS or ALK. What does this mean? Because this significantly changes the survival of these patients and the treatment that oncology can offer them. When we analyze these molecular subtypes, we see the evolution of the ideal patient. The ideal patient that some years ago were patients that did not have an advanced lung cancer to actual patients in which, in many cases, the disease is metastatic, and we are asked to admit them to the ICU because of the compensation of the disease. So there are subtypes in terms of staging and locally advanced cancer. We see one third of the non-small cell carcinoma, which come in stage 3 at the time of diagnosis. Standard therapy continues to be radio and chemotherapy. The mean progression-free survival was approximately 8 months, and that at 5 years, only 15% of those patients would be alive. These are statistics from 2017 that have been reviewed in these studies shown on the slide in 2025. What has happened? Well, the starting point was a progression-free median survival of 8 months. Currently, this has doubled. This progression-free survival rate is above 16 months. Progression free. So we are advancing to the chronification of the disease, a disease that used to be lethal until a few years ago. So life expectancy has increased, and this is a criterion to be considered. And we have changed from a survival estimated at 15% at 5 years to an estimated rate at present, a survival rate with new drugs such as durvalumab, to 42.9%. So there has been a considerable change in the life expectancy. And the statistics that were related to the classical concepts of cancer disease has been affected by this data. This shows that we have to change our perception, and this is going to be one of our conclusions. Our perception about the cancer patient. In the case of non-small cell lung cancer patients, stage 4, with no specific treatment established, around 50% of these patients were metastatic. The proportion of metastasis is increasing. And when there was distant metastasis, 5-year survival was 5.8% max. These are very recent statistics, very recent studies from the United States. And the current treatment options include immunotherapy and chemoimmunotherapy, very novel modifications of treatment, even with oral therapy. And we see that this percentage survival of 5 years has changed to 31% and continues to increase, with immunomodulators such as fibrosumab, expensive medications, but they are having direct impact on patient survival, increasing it 2 or 3-fold as compared to the conventional therapies. And the case of stage 4 non-small cell cancer, where there are therapeutic targets, and let me mention very briefly which are the most frequent mutations both in adenocarcinoma as well as in squamous cell carcinoma. We are now able to determine to a high degree of these types of cancer the presence of identified treatable mutations. What does this mean? Well, now we have updated survival data, which are very novel, and we don't have to try to know who is going to advance in the lung cancer pathology, but who of them are going to become long survivors. So the expectation of ability to recover in the ICU changes significantly because we are no longer in the face of a patient for whom we couldn't do anything, but a patient that has a potential to be a long survivor or a patient with a chronic cancer pathology. So where is the prediction phase? From oncology, we are told which are the ones that they consider the patients that will have a good long-term response. Patients under 65, patients with a good baseline status, a COG 0 to 1, body mass index over 24, when these patients are admitted to the ICU, the muscle mass or the BMI is a protective factor vis-a-vis polyneuropathy. The PCR albumin ratio below 0.07, and this is a lab determinant which unfortunately is not available in many places. And it's the determination of the circulating tumor ADN values or DNA. So we have it experimentally, but it's available in our hospital. This is a referral hospital for cancer. So the ability to quantify the circulating DNA is a very positive prognostic factor. And the ability we have to identify an increasing expression of ligand 1 of the programmed death protein. This is able to significantly change the natural evolution of the disease. And of course, we have also realized that the presence of adverse low-grade immunomediated events translates into longer survival. It shows the immune capacity or ability to reject the tumor that has been treated. Therefore, the higher the survival, the higher the probability of experiencing critical events or complications. So intensivists begin to participate.
In many cases, we underestimated their entrance to the ICU. And why did they call intensive care physicians for these patients? Because of the comorbidities associated to the cancer or the treatment, hemoptysis, obstruction of the airway, the increase of COPD because many are smokers. So we have parenchymal disease because of obstructive disease, pulmonary edema of cardiogenic origin, or several acute coronary syndrome because of the hypercoagulability status associated to cancer. So many of these complications, when they appeared, they came together in a patient with an advanced stage while they were underestimated to go to the ICU. And what was expected from us is that we were able to provide ventilatory support to that organ dysfunction that was a single organ many times, and it was the lung. Have mortality rates changed in this type of patients in the last decade? Well, the answer is a radical yes. In this analysis that I'm quoting here at the foot of the slide, it shows how the mortality rate that used to be 60% at the end of the 90s has come down to 28% in 2021. And I can anticipate that the new statistics talk about mortality rates that have come down even more when adding the new medications. It's true that overall statistics do not reflect this because the penetrance or penetration of these drugs or their distribution or their use around the world, many countries where they are not even available. So these predictors I mentioned before, which were the long survival predictors, but how can we know then what are the predictors of a bad prognosis, even with these new drugs, recurring or progressive cancer that advances despite the optimal treatment, metastatic disease, but not the oligometastatic disease, but the plurimetastatic disease that involves the central nervous system that is a marker of bad prognosis. Worse functional status, ECOG 0 and 1, I have mentioned, are protective factor. Patients with a worse functional status or that are or with lower capacity of biologic reserve in terms of muscle mass have worse performance. Classical scales like the Apache high scores, a PAFI under 150 for natural reasons. And this is a mortality factor independent of the cause of the respiratory failure, the serum lactate levels, and the use of non-invasive or invasive mechanical ventilation when we have intubation. And what is being advocated for is the use of non-invasive systems, such as high-flow nasal cannulas, to try to overcome hypoxemic response due to immunotherapy. And the short-term results, when all of these data don't come together, they are not significantly different between patients with respiratory failure with lung cancer and the general population. There's no impact in mortality to 28 and 90 days. The fact that they have had a recent chemotherapy, which is surprising because chemotherapy increases the risk of neutropenia, but the overall inflammatory response is a little bit lower because of the immunosuppression, and that the number of prior lines of treatment is not a determining factor when these new treatments came together. If this is a patient where we're thinking about starting immunomodulators or advanced therapies, the number of prior lines of treatment is indifferent because these drugs that are able to modify the disease will do it independent of the fact that they did not respond to prior treatments. So the therapeutic moment that the patient is in and the type of drug that is being used are crucial. Thus, the need that intensive care physicians are trained or that there's direct communication, in this case with oncologists, because this type of treatment is progressing very fast. We're thinking about adding around 8 or 9 drugs in the next 2 years, each one with an impact that can add to what already exists. So we need to advocate to a collaboration model where the ICU needs to speak directly with the oncologist in their own language. And of course, not to forget the importance of respecting patients' autonomy in terms of decision making. That can be patients that are candidates to complete support, vital support, all of the equipment in the ICU, or patients that can be not underestimated. They can be admitted to the ICU, but we would call group number 3 patients that go to the ICU with a limitation, a therapeutic ceiling that can be candidates to the use of vasoactives if they have a respiratory response because of immunomodulators, or as I mentioned before, the use of high flow systems in a controlled environment, but that could not be intubated because the intubation is an independent factor or for bad prognosis. So in these patients, we have to establish early on joint assessment and a care plan. When these patients come in, they should already have an assessment to see if these are candidates to be in the ICU or not, and not wait until the acute moment when early in the morning they call you because the patient has respiratory failure. And as for first-line lorlatinib or crizotinib, specifically in lung cancer that is ALK positive, we see responses like this one where we see pulmonary involvement that is massive, and how in the right lung that you add an infectious infiltrate. This is the case for my hospital, and how we can have almost a complete response over no more than 1 week. What we interpreted as an infectious problem was more inflammatory because of the tumor response. So this patient changes radically. And we have seen on a previous presentation how we had to be patient with respiratory distress or respiratory failure. The responses can be marvelous. Our attitude towards these patients has to evolve. I've mentioned before that one of the criteria to underestimate entrance to the ICU or admittance to the ICU, and that we underestimated it, was massive occupation of the airway. We have a case that we saw at this hospital as well. They come into the ED, a 68-year-old male with a non-microcytic lung cancer, massive respiratory failure, almost without lumen in the airway, and how after about 12 days of treatment with alectinib, the airway has been recovered. This patient had to be ventilated first with a tracheostomy, and then when there were controls, we see that the patency of the airway was recovered. and patients that, of course, would have not been considered in normal conditions or would have gone to sedation immediately. So take-home messages. In cancer patients, the main cause of admittance to the ICU continues to be respiratory failure. 36% of these approximately develop respiratory syndrome. Most of these have major comorbidities, and this proportion is increasing as we have patients that are 80 or 90 years old. Recent trials suggest that there's an improvement. We have significant improvements in the prognosis of these patients, including those that have ARDS and that require mechanical ventilation. And we have to be aware of the fact that we have to forget those false beliefs that are not updated regarding prognosis of severely ill critical patients. We have to admit to the ICU and not underestimated, thinking that there's presence of a neoplastic disease in an advanced stage. We have to see what type of treatment oncologists are suggesting those that are in our hospitals. So final reflections is that survival rates have improved substantially in the last 2 decades. And despite these advances, we continue working to be able to identify predictive, reliable parameters for a clinical response, because the reality is that we still have a lot of uncertainty. And as I mentioned, with the COPD trial that was 20 years ago, to date, in the case of cancer, we have a lot of uncertainties that normally lead us to underestimate patients. Every patient has their own conditions by the onset of the disease, comorbidities, and associated complications, and time normally plays against us. Decision-making in the acute phase or in respiratory distress is not recommendable, and decisions regarding admittance to the ICU should be done before that, and that the more you prolong survival, overall survival, the more probability of having critical events that may require assessment or management in our ICU, where survival depends more on the functional status of the patient before this than the tumor disease in itself, because as I mentioned, we're advancing more towards trying to make the disease become more chronic, that it could occur that patients with lung cancer could die with the cancer, but not from the cancer. And that is an enormous change. So this is a picture of my hospital. And I think those were the reflections I wanted to share with you today. But we had to do it very fast. You have my email here in case you want to contact me or if you have any doubts. And I have Dr. Jose Manuel Gomez Garcia to continue with the talk he had prepared.
Muchas gracias, Julio.
Thank you, Julio.
Mi pantalla.
I will share my screen.
Creo que puedo empezar.
So I think I can start.
Bueno, muchísimas gracias a los organizadores.
I want to thank the organizers, especially Dr. Julio Villanueva and Dr. Pablo Cardinal, that besides sharing patients and we have the same specialty, we have a friendship, and that is an honor for me. And I also want to thank the rest of the organizers and sponsors and FEPIMCTI for this very interesting scientific event. Dr. Villanueva's talk, I thought, was extremely important and interesting, with a lot of information, because behind the scenes, Julio and I were talking before the session that what he was talking about reminded me of the years where our mentor and professor, Dr. Eugenio Guerrero, was talking about patients, how in the 80s, HIV patients were underestimated to go into an intensive care unit, and that radically changed. And that disease became a chronic disease that is absolutely manageable in the intensive care. especially with its complications. And I think it's interesting because what could seem very bad in the 80s and 20 years later, we have seen that that has changed and that it's fair from the point of view of distributive justice and equity that this happens, and it's happening with patients with cancer. This is a basic lesson that science and bioethics have to go together, both one and the other. Science cannot move forward without ethics, and ethics changes its paradigms and how to apply those principles based on science. And that gives us clinical scenarios where the paradigm changes and our clinical practice changes as well. And I'm going to talk about a new paradigm, the post-intensive care syndrome, the post-ICU syndrome, where intensive care physicians have realized that we have to also look after the sequelae that our patients have after leaving the ICU. The advances in knowledge in intensive care have allowed us to have spectacular results in terms of survival. Going into an ICU is no longer similar to, say, to a absolute death, but fortunately almost the opposite, guaranteeing the survival of patients that suffer from serious diseases so that they can overcome these events and move on with their lives. Scientific society and intensivists also reflect and realize that our treatments, our devices generate problems or sequelae, physical sequelae, cognitive and psychological sequelae, not only in patients, but also their family members. So we also need to face those. And there's a new paradigm where we have to focus not only on the life of our patients, but also their quality of life after being discharged from the ICU. And that is one of the new challenges in our specialty, in the intensive care specialty. To look at the toll that many patients and families pay when they go through an ICU. And then we have the post-ICU syndrome that generates new decays or worsening of the physical, cognitive, and psychological status of our patients. And this is an entity that is described in 30 to 50% of patients that go through an ICU. And in some spheres, the cognitive sphere, there are trials that show results of almost 80%, some type of cognitive sequelae after having been in an ICU. And it not only affects the patient, but also the family members, with a family PICS that is expressed in the caregiver, the main caregiver, after discharge from the hospital. The family that is closest is the main caregivers that psychologically suffer a lot or emotionally suffer a lot. Scientific intensive care societies around the world have that they're interested in this syndrome and facing it as a public health challenge that supposes an increase of the needs of people in terms of health or dependency as well. We still need data, unfortunately, in terms of survival after discharge, quality of life after discharge, to specifically see what those needs are and to be able to adequately organize continuous healthcare and have the necessary resources to these patients and families so that they can overcome this post-ICU syndrome. Intensive care physicians have discovered, by reflecting and observing, that we do have these sequelae and that this syndrome exists, and we're forced to not abandon our patients because of ethical responsibility, and we need to accompany them in this healing process.
rehabilitarles y
even trying to
reincorporarlos.
rehabilitate them so that they can go back to an
Estas
optimal
son
quality of life.
las esferas
And
fundamentales del
these are
síndrome
the
post-UCI.
fundamental areas of the post-ICU
Podemos
syndrome.
considerarlo
And we can
como un daño, como un
consider
evento
it
adverso
an adverse
que
event
sabemos
or
que es
harm
inherente, ¿no?, a la asistencia a
inherent
cuidados intensivos, pero
to
que
being in the
desde
ICU.
luego es evitable o cuanto
But
menos
of course,
evitable,
it
¿no?
is avoidable, or at least we
Entonces,
can minimize it.
parte de nuestros esfuerzos
And part of
asistenciales
our
en la
healthcare
estancia y en la
efforts
post-estancia
in
deben estar
hospital stay or ICU
a
stay
mitigar
have to be
estas secuelas
focused
del
on
síndrome
mitigating
post-cuidados intensivos.
this post-ICU syndrome.
El deterioro físico se manifiesta sobre todo
Physical decay is seen especially
y la persistencia de esta
in the
deficiencia
ICU and the muscle weakness acquired in the ICU with malnutrition,
también el dolor
sarcopenia,
persistente
also persistent
en
pain.
nuestros pacientes, el deterioro cognitivo,
Cognitive
se ve
decay,
afectado la memoria,
we see there's memory
los
loss,
procesos mentales, la
speed
atención,
of mental
y a nivel
processes is delayed.
psicológico
And at a
existen
psychological
claros
level,
síntomas
we have
de
clear
depresión,
symptoms
insomnio
of
y
depression,
ansiedad y
insomnia,
estrés. En la
anxiety,
familia
and post-traumatic
también
stress.
aparece
And in the
varias esferas
family, there are several spheres
del síndrome post-UCI familiar, ¿no?
of the
No
family
solamente a
post-ICU
nivel
syndrome,
psicológico
not only at a
y
psychological, physical,
emocional, sino
and
también
emotional
económico, ¿no?
level, but
Estrés
also at an
constante.
in economic
Desgraciadamente,
terms.
muchas familias
And
sufren
unfortunately, many
una
families
carga difícil de
suffer
situación, ¿no?
this as a difficult
Desde el
burden.
punto de vista del cuidador, pues
In
también
terms
debe
of a
ser el
caregiver,
cuidado
they have
familiar, ¿no? El
to
cuidador
be cared
principal.
for. The main
Y
caregiver has to be looked after as
tratando
well.
al paciente podemos
And treating the
tratar también a la
patient, we
familia
can also
y
treat the family
convertirlos en una unidad única de
and have
cuidados.
them become a single unit of care.
Para enfocar más adecuadamente este paradigma, este nuevo
So that we can look at this new
síndrome
paradigm
post-UCI,
or this
nueva entidad
post-ICU syndrome,
clínica
this
surgida
new clinical
de
entity
los ingresos
that
en
has
cuidados
appeared
intensivos, yo
from
creo
admissions
que
to the
es un
ICU.
enfoque
I think
mucho más basado en la
that we have to
cronología
base the
del
focus
proceso,
more
más a largo plazo,
on a more long-term
de los
process, a more chronic
infrarrecompensas
process of uncertain recovery that is complex,
entran a formar parte aspectos, como hemos visto,
where
diversos,
aspects,
físicos, cognitivos y
several
emocionales,
aspects,
que
cognitive,
requieren
physical, and
un
emotional
abordaje
aspects come into play,
multidisciplinario,
and
no
that
un
require
abordaje
multidisciplinary approach,
fragmentado.
but not a
Eso es uno de
fragmented
los
approach.
grandes carencias de
This
nuestro sistema
is
sanitario,
one of the problems in our health system, fragmentation in healthcare and lack of
entre los
coordination
distintos especialistas.
between the different
Yo creo
specialists.
que es una de las de los cambios
So I think that
fundamentales
is
que
one of the
debemos
fundamental
establecer en nuestros
changes that have
sistemas.
to be established
Una
in our health
coordinación
systems.
eficiente,
Efficient
incluida
coordination
entre los especialistas hospitalarios, los
between
intensivistas
hospital specialists,
y la
intensive
atención
care
primaria.
physicians, and primary
Debe
care
ser
physicians.
una atención primaria
This has to be primary care
que conozca todos los aspectos del
that knows
paciente una
about
vez
all the
salido
different aspects of the
del
patient once
hospital.
they have been discharged from the hospital.
Tiene tiene que ser tratado precisamente
And
porque
this has to
pueden ser
be
vulnerados o
paid attention to
estar perjudicados no solamente por su enfermedad,
because they can have problems not only because of their disease, but
sino
because of an
también
adequate
para
design of the health
las
system
necesidades
to be able to
de
face
esta nueva
their
cronicidad
needs
de
and
este
this
síndrome.
new chronic status that is
La
the
estancia en UCI
post-ICU
no
syndrome.
solamente provoca su incidencia, sino
The
también
hospitalization in the ICU
incidencia
is not only during the
genera
critical care, but when
disruptivo
they're
en
healing, that
los
generates
enfermos,
disruptive problems
porque
and
se produce una
deceased
pérdida de
or
identidad
ill
y
patients. There's loss of
existen
identity
cambios
and of
físicos,
appearance because there are
lesiones,
physical changes, physical
evidente una
deterioration,
pérdida de roles,
and loss
de
of
identidad.
their
Pues cuando alguien
roles,
está
loss of
en cuidados
identity.
intensivos,
You go into an
siendo por
ICU,
ejemplo médico intensivista,
being, for example, an intensive care
pues a
physician,
cualquiera nos puede tocar una enfermedad
and
crítica
this
y
could
sale
happen to any of us, a
de
critical
la
disease,
unidad de cuidados
and they
intensivos a
leave
casa
the
ya siendo otra
ICU
persona,
to go home,
ya
being a
siendo
different
un
person,
paciente que ha perdido
being a
el
patient
rol profesional.
that has
También
lost their
existe la
professional
pérdida
role.
de habilidades
There's
sociales,
also loss of social
habilidades
skills,
administrativas,
administrative and
comportamiento,
professional skills, in terms of paperwork.
Existe una pérdida de soporte
There's
social,
loss of social support.
en
There's
cuanto al aporte
a gap in
soporte
terms
social, la
of
necesidad de
social
servicios sociales
support.
que tienen las familias
All of these social needs that families have
con una convalecencia
of
crónica y compleja.
patients that have a complex situation
Una pérdida
such
de
as the
sentido,
post-ICU
sentido
syndrome, and loss of
muy
sense
mermado en
because
sus
they are
capacidades
deteriorated in all of their
competencias
capacities and all of their skills.
y en su papel
And
en los ambientes
in the
sociales
role they have in different social, professional, and family environments. And there's also a loss of their history, where none of us includes that disease.
ruptura de una biografía
And that
idealizada
rupture of an idealized history of a person that is free of disease
una situación de vulnerabilidad y de
generates vulnerability and dehumanization of the patient after being discharged from the
para
ICU.
afrontar adecuadamente desde el
And
punto de
to
vista de la ética
adequately face the post-ICU syndrome from the perspective of ethics,
diferentes conceptualizaciones,
ethics has different ways to apply it or different concepts and profiles. And one of these is the ethics of care. I think that the ethics of care is the one that adapts best to the post-ICU syndrome because it has emotional, social, and contextual aspects in the profile of a patient that is suffering from the post-ICU syndrome.
concreción de los cuidados en una persona.
And we have to look at all this care in a single person. The principalist ethics is different than the person-centered ethics, the specific person. Ethics of care considers emotions, moral decisions. Ethics of care goes beyond autonomy, or they understand autonomy in a different manner. Shared autonomy, interdependence, shared decision-making. The ethics of care is based more on vulnerability, the vulnerability of people. That's what makes all of us the same. That fact that we're vulnerable, we're similar. And that connects us to other people. We depend on other people. And the ethics of care, ethics of care was studied and developed by two philosophers that were very important, Levinas and Martin Heidegger. Levinas spoke of the face of the other, the nudity of the other, and that other is the one that invites me, that asks for my help, asks for my attention and for my care. The caring for other as a moral imperative, according to Manuel Levinas. And then Martin Heidegger
speaks
about the existentialism of care.
Existentialism of care,
based on
one of the fables of Dino, who was a writer of the first century
that was
born in Valencia, and he's Spanish-Roman. Higino wrote about mythology, and one of his fables spoke about care, the ontologic condition of the human being. For Heidegger, care was prior to the human being. Without mutual care, we wouldn't be able to build the dimension of the human being. So care is fundamental to understand us as human beings and as mankind. Which are the key bioethical principles in the post-ICU care? Well, one of them is vulnerability, to recognize the frailty of the patient and dependency. This vulnerability is not just a result of the disease itself, but of the lackings. Vulnerability from the point of view of justice implies preferential treatment to the needy people, the most vulnerable people. It's to use what we call positive discrimination, and this is one of the essentials of ethics. The protection of the weakest, to give more to the one that needs the most. And this fundamental trait of ethics differentiates us from wild nature, where natural selection prevails. So this differentiates us from immoral societies to be responsibly taking care of the weak. Another principle is integrality or wholeness, comprehensiveness, to take care of the individual in a comprehensive manner. This biopsychosocial approach is necessary and fundamental to respect human dignity. This is another fundamental principle. And we spoke about interdependency, relational autonomy, not based on paternalism or autonomy, but sincere relationship with the patient and the family. These are fundamental ethical principles. There is an ethical dilemma when discharging a patient from the ICU. And intensivists have the ethical obligation to reconsider whether at discharge we must be responsible for the care and follow-up of the sequelae of patients before the ICU. So there are some pros and some cons. Values in favor of follow-up or monitoring include over-medicating patients, stigmatizing patients, subject them to a label of a new disease, which makes them feel different, to overburden the person and families with excessive controls and medical visits, overloading the system that is against these values, and invade the patient autonomy, forcing the patient to a follow-up. But then there are also some positives with this post-ICU follow-up. Number one is that we are not just concerned about years of life, but to add life to the years. In other words, we must be concerned about quality of life of these patients discharged from the ICU. We must be responsible for any adverse events which occur in our ICU. And the best way to be responsible is to do proper monitoring and follow-up of those sequelae and to treat those sequelae. We have to be part of that comprehensive approach that we mentioned, the globalized care, and to improve that continuity of care. This also gives us knowledge and experience. Know what was the experience of the patient and families while they were in the ICU, because that will help us to improve and to meet the needs of the caregivers. This is another value in favor of follow-up of patients post-ICU. How do we strike a balance? Well, the main pillar is to prevent the post-ICU syndrome. And there are a series of fundamental measures to prevent this post-ICU syndrome. Another balanced solution is to do a selected follow-up of patients at risk, to be selective with these patients with a high risk of post-ICU sequelae, and to establish a healthcare balance where we weigh the excessive medication with the right care for post-ICU sequelae. Among the prevention strategies for the post-ICU syndrome, There are very well-known strategies, very extended strategies in the area of intensive care. A package of ACDF, ABCDEF measures, and ECASH model. Both of them are based on a good use of analgesia, sedation, delirium management, physical therapy, and involvement of families. Then we have the project HUCI, Humanizing Intensive Care. It's a very humanistic project focused on the dignity of human being with the people at the core. All the people involved, patients, families, and practitioners. Patients and the main characters of the process, the main actors of the process, families that must be involved in the team, and they are fundamental for the recovery of the patient, and practitioners that also have needs and are overworked and need training and assistance and a leadership to orient them towards the correct performance of the roles. These measures, preventive measures of post-ICU sequelae, are of the essence if we want to address these sequelae. Therefore, we have to reject the fragmentation of the system, integrated, coordinated, and this is an obligation, this is an ethical imperative to ensure comprehensive care of post-ICU patients and family. We have to identify patients at risk previously, do prevention for the post-ICU syndrome. We have to do follow-up in our offices of these patients and coordinate with primary care and other specialists that should be involved and play an important role: rehabilitation, psychology, nutritionists, pulmonologists, ENT, and different specialists that must get involved in the care of these sequelae. So, as a conclusion and as a final warning in this post-ICU syndrome, we must take into account that it's an adverse event that we have to prevent. And we have to work together with nurses, with psychologists, rehabilitation, and with the families to minimize as much as possible post-ICU sequelae. We must have the approach of a chronic, complex, and long process. This allows us to have a more adequate conceptual framework to ensure the integral recovery of our patients. And we have to adopt humanized measures, evidence-based, A, B, C, D, E, F, ECASH, and the HUCI projects are clinical effective interventions that should be systematically implemented in every ICU around the world. And we must ensure continuity of care because this vulnerability, because of our system that doesn't take care of the patient as a whole, is a ballast for the recovery of our patients. So a warning is that we have to train our professionals, not just residents, but also specialists and nurses in the post-ICU syndrome. Studies have shown that residents who participate in post-ICU follow-up programs change their daily practice, mitigating and preventing the occurrence of the post-ICU syndrome. And we have the responsibility of not to neglect our patients after leaving the ICU. It requires our professional involvement
provisión de recursos necesarios
The necessary resources must be provided to meet the
y dar
patient's
una
needs
asistencia coordinada.
and to provide complete
Solo
and
a través de la educación y
comprehensive
el trabajo en
continuous
equipo
care.
podemos asegurar el
Only
éxito de
through
nuestros
education and
dispositivos
teamwork we will
este
be
éxito
able
no se
to
mide
ensure
solamente por el número de
success in the
participamos,
ICU,
sino por
measured
cómo
not just in terms of
devolvemos
the
la calidad de
lives
vida
we
que podemos dar
save,
a quienes
but
participan
also
y
based on the
mejorar
quality
nuestros
of life that we
procedimientos
can provide our
de vida.
patients after being discharged.
Estas son la biografía y las fuentes
This is the
bibliográficas de
bibliography I have
la
used
charla
for my
y
presentation,
nada más.
and this is
Mi
all.
correo electrónico,
This is my email, just in case you want to
en
ask me
cualquier
any
unidad de
questions.
cuidados intensivos del Hospital
In
Gregorio
the
Marañón estamos
ICU of
encantados
our
de
Gregorio Marañón Hospital, we have a
buenos
post-ICU visit
resultados
with very good
en cuanto a
results
experiencia y
in
satisfacción de los
terms of
pacientes,
patient
con una
experience and
situación
satisfaction.
mejorable y que estamos construyendo con el
We
resto de
are
especialistas y con los
building
equipos.
teamwork with the
Nada
rest of
más,
the
estoy
specialists and
atento a
primary
cualquier
care.
cuestión que
This would
podáis
be
tener.
all, and I will be willing to answer any questions you may have. Thank you so much.
Creo que queda abierto el turno de preguntas.
Well, now we
Ya
can go on to the
creo que
Q&A
nos
session.
habéis comentado una pregunta, ¿no?
I
¿Cuál
think that there
era
is a
los factores
question,
pronósticos
which are the
en
prognostic
pacientes con cáncer de pulmón
predictors
fase
of
4
a patient with
que
phase
presenta
4
erosión
lung
aneurisma
cancer with
recurrente,
malignant
crónica con
relapsing
pleurodesis
pleural
o
effusion
antecedentes de
with
enfermedad
an
cardíaca,
indication
fallos
of
cardíacos,
pleurodesis with a
falla renal
history
o
of heart
cirrosis,
failure,
¿no?
kidney failure, and COPD.
En este caso, ¿no? Lo que yo,
Well,
por la
in this
experiencia que
case,
tenemos nosotros,
according to our
esta respuesta
experience,
necesitaría conocer
this would
el número de
need
sitios en los que hay
uh,
metástasis, porque
well, how many
muchas
metastases are present? Because
asistencia central
if
encima
the
de los factores
metastasis
normales
is
de
to the central
pronóstico,
nervous system, it's a
saber
very
si
poor
concurre o
prognosis.
no
We need
un
to
proceso
know the
de tratamiento
coexistence of
guiado por dianas terapéuticas y
therapeutic guidance
bueno, pues si ese o
treatment
no, por la concurrencia de un
and
fracaso o una disfunción renal
uh, renal failure
cardíaca, pues
and cardiac
posiblemente
failure
el derrame pleural posiblemente
and
sea
the
un
pleural
paciente
effusion.
mucho
Probably
malo,
this
¿no?
is
Con
a patient with a
un
very
nivel
poor score,
funcional malo, ¿no? A
with a
priori,
very poor
confiando que
functional
no
level.
conocemos el número de sitios en los que hay
We
metástasis
don't
y
know how many
no conocemos el tipo de
metastases or the
tratamiento que se
size of the
ofrece,
metastasis,
habría
and
que
we don't
ser
know
conscientes
what
que
treatment is
una,
being offered.
una
But in
espectacularidad
any
y
case,
una
this patient
espectacularidad
has
de pronóstico bastante,
a
bastante malo. No sé
very
si
poor
era eso a
prognosis.
lo que se
I
refería o
don't
si
know
había cambiado
whether
la
this
pregunta, ¿no?
is the question.
Bueno, si no hay feedback, creo que hay una
Well,
pregunta
if
que
there
va
is no
dirigida
feedback, there is
específicamente,
another
creo que es
question,
más a José Manuel, ¿no?
which is, I think it's
Respecto
addressed to
a
Jose Manuel.
si tenemos dudas sobre cómo
A ver,
abordar
If we have any doubts about, yeah,
no veo la cuestión en el chat.
te la transmito yo que la estoy leyendo ahora.
Vale.
well, let me read the
¿Tenéis
question.
dudas sobre cómo abordar el final de la vida?
Have
¿No?
you
Bueno,
any
antes de la
doubts
próxima
about how to
quieren
approach
que nos
end of
pregunten, pero
life?
veo aquí que
Well,
esta pregunta es para todos.
this question is for
¿Qué opinan de la
everyone.
futilidad
What do
terapéutica
you
y
think
quién puede o
about
debe garantizar que no
therapeutic
suceda?
futility and who should and make sure that this doesn't happen?
Bueno,
Futile
la
therapy.
futilidad terapéutica es
Well,
el concepto de
futile
futilidad es
therapy, that
difícil de
concept
plasmar, ¿no?
is difficult
con
to
palabras, ¿no?
explain in words.
Bueno, decía que es todo aquel acto médico, ¿no? Que
Any
no
medical
garantiza una
action that does
mejoría
not
pronóstica
ensure improvement in the
de los
prognosis
pacientes y que
of the
conlleva unas
patients
cargas
and is
enormes,
associated
no solamente
to
de salud, sino sociales,
uh,
económicos,
health, social, and
excesivos, ¿no?
economic excessive burden.
En el ámbito de los cuidados intensivos,
In the area of intensive
cada
care,
vez utilizamos menos el término
we
futilidad
are using less
y
and less
utilizamos
the
más
term
el término
futility
de
or futile. We prefer
potencialmente
the
inapropiado,
term
¿no? Porque se
potentially
ha aprobado
inappropriate measures
todas
because,
las
as
decisiones
Julio
deben ser
said,
individualizadas,
all decisions have to be
porque todas las
individualized.
decisiones deben ser
All decisions must be considered within a context. What may seem futile in one particular patient may not be futile for another patient. In any case, these decisions must be by consensus, based on current scientific knowledge, taking into account the values of the patient and the family, and it should be a meditated decision with the participation not just of intensivists, but of other specialists that have something to say about the prognosis of the patient, the underlying disease or the disease that brought the patient to the ICU. And with regards to futile treatment, the adaptation of the measures, it's very difficult to give figures. People want to hear figures or numbers, but these criteria are based on 3 pillars. The decision-making must be oriented towards the probability of success of treatment, the years of life that can be offered through that treatment, and the quality of life. In the case of probability of success, in the case of lung cancer, it has doubled or tripled depending on the therapy administered. So the specific treatment is determined by the presence of certain markers, and this is technical information that we should have available. If that information is not available, we may be extremely subjective. And we are at a world forum. I am perfectly aware of the fact that these markers are not universally available. It's not easy to have access to them in every place. But when we try to establish what is the limit of futility, what percentage does it apply, there is a consensus that establishes that an X measure, if it has a success rate lower than 5%, that is the numerical value of futility. But really, I think that that number is just a consensus. It's not an actual technical number that is reproducible. And I was mentioning before in the previous question that they didn't know where the metastasis was, and the metastasis was suprarenal. The nature of stage 4 of the tumor is not the central nervous system. That's independent information. The metastasis is not a bad prognosis marker in this specific case. Well, I see that there aren't any more questions. We are within our schedule. So I think that both Dr. Garcia and myself want to thank you for participating in this part of our meeting. And the bioethics session that we want to keep as part of our meeting, of course, we are willing to invite other colleagues. I would like to invite you to suggest proposals for next year's meeting. Thank you very much. Thank you.